Hi, everyone. Thank you for the introduction and invitation. So the previous speakers made my talk a little easier. These are my disclosures. So they already mentioned, the data and the available data and the need for randomized trials. As we all know now, acute PE and in general VTE remains a significant cause of morbidity and mortality across the world. There are so many different treatment options. The anticoagulation is still the mainstay of treatment, as we know. And then, depending on the risk stratification of the pulmonary embolism, then, escalation of treatment plays a role, especially when it's high-risk PE and intermediate-risk PE. And the data that we need exactly is in the intermediate-risk PE space or the submassive PE space. So I'm going to talk about the catheter, which is the BASHIR endovascular catheter. So basically, it is a low-profile 7 French catheter that goes over an 018 guide wire. It has a spiral-cut nitinol reinforced infusion basket, basically 6 mini infusion catheters with multiple holes in it. It comes as a collapsed straight catheter that can expand at the site of the thrombus. And basically the theory behind, developing the catheter and using it is it's gonna create multiple fissures within the thrombus itself. And theoretically, also create a large central channel to allow for immediate or almost immediate blood flow into or through the thrombus. And theoretically, the endogenous fibrinolytic effect of the blood of the patient going through the thrombus probably can be an additional factor in addition to the exogenous TPA or the thrombolytic infused through the catheter. So as you can see here, the catheter, when the basket is expanded, it might have a larger cross-sectional area. And this expansion also might create some fissures within the thrombus. It also has indications. It's not FDA approved for PE. It has indications for DVT. So it's a dual, there is this BASHIR Plus, which is dual lumen infusion catheter with the basket at the distal end and also a shaft of infusion with different length that can be used for deep venous thrombosis. So this is basically the potential advantages of the catheter. Of course, there are so many devices in the field, whether thrombolysis or thrombectomy devices, but the potential advantages are no blood loss, prompt restoration of the blood flow because of the creation of the fissures, and the wider cross-sectional distribution. And based on these potential advantages, the potential implications can be reduction of the duration of the treatment, which causes reduction of the dose of the thrombolytics and reduction of the major bleeding rates. Of course, we need more data from the literature, but these are the potential implications and the potential benefits. So how do we use the catheter, basically? You need always to think about your procedural toolbox before starting the intervention. This is how I always think about any intervention is, do I have the equipment and the expertise to do it? So basically, because it's a 7 French catheter, you're gonna need an introducer sheet of 7 or bigger French catheter or sheet. It has to be less than 75 centimeters, and also it has to be long enough to reach the target pulmonary artery, because you're introducing the catheter over an 018 wire, and then you're gonna basically unsheath the tip and expand the tip or the basket at the end of the catheter. You're gonna need wires, of course, 018 wire because the catheter goes over an 018 wire, and 035 wire exchange length wires, swan gans or angled pigtail catheter to get access into the pulmonary artery. Preparing the basket on the table, basically testing the expansion and collapsibility of the device, and basically you can expand and collapse the basket using that handle. Flush the wire lumen as any other device that we use, and then flush the basket infusion port while expanded. You can do it through a femoral or IJ access as any other PE intervention. In general, when I do thrombolysis, I go IJ, but I was one of the investigators in the trial, so I was doing bilateral femoral access. For this specific device, because it's easy to fix on the legs of the patient, because you always have to think about dislodgement of whatever device you're keeping in the patient, especially when you're sending the patient from an interventional suite to the MICU or observation. So I found femoral access is, for this specific case, is easier or safer to use. But there are people who use IJ access. You select the PA as any other PA intervention, pressure measurements, PA gram. I tend to limit the pulmonary angiogram to avoid increasing the load on the right ventricle and avoiding the patient collapse on the table. If I do any PA gram, I do like a hand injection just to confirm the location of the catheter. Then you advance the sheet into the pulmonary artery over an 035 wire. Then you replace it with an 018 wire because the device itself goes only on an 018 wire all the way to the end. So basically in this picture, you can see that if you're thinking about infusing along this thrombus, you have to advance the sheet almost all the way to the end of your target pulmonary artery and then place the device, then unsheath it before expanding it or expanding the basket. Usually, at least in the rescue trial protocol, we had to start a TPA infusion while the catheter is loaded on the wire just before introducing it into the sheath. And once at the target TPA, pulmonary artery, you unsheath it and you start, well, the infusion is already on the way, so you continue the infusion. In the rescue protocol, we had to expand the basket, do 1 milligram pulse TPA injection, and then collapse it, expand it again, another 1 milligram, then start the infusion at 1 milligram per hour for 5 hours, which ended up with a total 7 milligram TPA. 2 of them as as a pulse spray and 5 milligrams over 5 hours infusion. If it's a unilateral, and a total of 14 milligram if it's a bilateral pulmonary artery thrombus. Akil showed a lot of these results from the rescue trial, which was published recently. So I'm going to go quickly over it. Basically, it was a single-arm, again, prospective trial that enrolled 109 patients, 18 US sites, and the trial was from October 2020 to May 2022. These are the baseline characteristics. 90% of the patients actually were in the intermediate high risk category with both elevation of the biomarkers and right ventricular dysfunction. The primary efficacy and safety outcomes are shown here. Basically, it showed around 33% reduction of the RV to LV ratio, which was also statistically significant. Major bleeding rates were very low, and major device-related adverse events were also low, less than 1%. Hemodynamics, basically the systolic pulmonary artery pressure decreased from the baseline to post thrombectomy or thrombolysis or CDT, which was statistically significant. The cardiac output and index improved also. The pulmonary artery obstruction index also decreased, and there was around 36% reduction, and it was statistically significant. So as a conclusion, the rescue trial met its primary efficacy and safety endpoints. There are a lot of trials that already have been published and a lot of trials coming. As everyone, all the speakers touched on, randomized trials are very, very important, specifically comparing catheter-directed treatment plus anticoagulation to anticoagulation alone, and that's where the PE track can play a major role. And also, as Dr. Sista mentioned, it will evaluate short-term or and long-term outcomes. Thank you.